Good afternoon, morning, everybody. My name is Emily Field. I am the Senior Evaluation Specialist here at USET, and you are being recorded. This presentation will be shared later on our YouTube channel. Welcome to our monthly infectious disease echo. We have two exciting presentations for you. Greer Harper will be giving influenza and COVID updates, and Dr. Mara will be sharing a presentation on HIV. I am just going to share some disclosure slides really quickly. Let's see. Oh my goodness, here we are. So this is a activity that's brought jointly by with Cardia Services. We are offering continuing education units for medical and nursing credits or completion certificates. In order to get the one unit, you must attend the full hour and a half, and complete the evaluation. You can also claim credits by attending this through viewing the recording online and then completing the evaluation. The relevant disclosures are Dr. Mara received an honorarium from AbbVie Pharmaceuticals for a presentation. He's also a PI for clinical trials for Gilead Sciences, Pfizer, and AbbVie Pharmaceuticals, and PI for Focus Grant for Gilead Sciences. All relevant financial relationships have been mitigated. And then Emily Field, me, a planner, has a relevant relationship with healthwarehouse.com and Pfizer. All relevant financial relationships have been mitigated. And as I said, you need to attend the full hour to get credit. Please complete the evaluation. You can also complete the evaluation if you just like to give us feedback. That would be great too. And your certificate will be sent by email. If you have any questions, please direct them to Michelle Doherty at Cardia Services, or you can contact anyone at USET and we can pass along your questions or concerns. And I'm going to share a link in the chat to the evaluation, and we will go ahead and get started with Greer's presentation. Let me just pull it up. In the meantime, if you'd like to introduce yourself in the chat, please do so. Share where you're from. This is a community of practice. We like to know who's joining us, and feel free to use the chat throughout to ask questions, have discussion. Following each presentation, you'll be able to ask questions out loud too. And go ahead, Greer.
There. I'm Greer Harper. I'm one of the staff epidemiologists here at USET, and this is part of the infectious disease echo for the respiratory illness report that we've been doing. My contact information is there, and then I'll also be adding it into the chat. Next slide, please. So in previous months, we've done a COVID and influenza report. We've kind of updated this report to include RSV as well as COVID and influenza. And we've labeled it the seasonal respiratory illnesses report. And we've kind of added a couple more things and a couple different metrics for the future for this respiratory season and in the next respiratory seasons. Next slide. So these are our data sources. We have 4 different sections for this respiratory illness report. We have influenza-like illnesses, which the data is from the Indian Health Services weekly influenza report that Anna and I receive weekly. It's part of the CDC's US Outpatient Influenza-like Illness Surveillance Network, or ILI-NET. We have a section for COVID-19, influenza, and respiratory syncytial virus, or RSV. And the data sources are for the NSSP, for the National Syndromic Surveillance Program, in conjunction with the CDC and the Department of Health and Human Services, PROTECT. We have a section for influenza, and the data sources include the IHS Weekly Influenza Report and the CDC's US Influenza Surveillance Report, surveillance system, and of course, HHS PROTECT. COVID-19 is specifically for COVID's, for the CDC's COVID data tracker. Next slide, thank you. So the first section is influenza-like illness. Next slide. This includes reported cases of fever and cough or sore throats, but are not laboratory confirmed as influenza. So the first metric is the percentage of IHS ILI visits. And this is the number of ILI visits divided by the total number of daily outpatient visits on the national IHS scale and the Nashville area IHS, which the Nashville area includes all US USET states. So we can see that the national IHS ILA visits have increased a little bit by 0.2% from last week, and it's a total of 1.5%. And then Nashville has increased a little bit by 0.6% to 3.9 this week. The next metric is the percentage of ILI visits by age. This is the number of patients visits with respiratory illnesses and the age range of the patients themselves. We have 5 age brackets, and they represent the 0 to 4 is our, and 65 and older are our most at-risk age groups. We can see that the 0 to 4 years of age bracket has the highest ILI visits. This is kind of on par for most respiratory seasons. We usually see children and adults 65 and older have higher percentage rates. So next slide. So this is the next metric is the influenza-like illness activity level by state. This map represents visits for respiratory illnesses that include ILI visits and other respiratory pathogens that can cause similar symptoms. The indicator on the right represents the intensity of the activity within the state jurisdictions. So we can see that Louisiana and the other states, if we're just looking at USET state metrics, is Texas, Louisiana, Mississippi, Alabama, Georgia, South Carolina, and Florida have probably the highest ILI activity levels this week, as well as Nashville in Tennessee. But the northern states and the northern territories seem to have a lower ILI activity level. We're just going to be following this every week. Some weeks are a little worse, some weeks are a little better. So we like to see these trends. The next metric is the percentage of outpatient visits for respiratory illnesses reported by ILI-Net. That's the CDC surveillance system. And this graph represents the percentage of outpatient visits for respiratory illnesses by season. The dark green on the left that seems to be climbing a little bit is this current season. It seems to be doing, there's not a big peak like we saw at this time that we saw in last year's respiratory season, but it is a little higher based on previous seasons. So every week we add in the new metrics and we kind of see it add in to the graph. And we like to just see the current trends to see if we're at a peak for certain weeks or if it's going to be going down for certain weeks. So we're going to be just monitoring this trend. Next slide. So the next system is COVID-19, influenza, and RSV. So this metric is the United States percentage of visits for respiratory diseases by week. This graph compares the 3 respiratory diseases we usually track for each respiratory season, and they're represented as percentage of all ER visits in the US. The red is the combination of the 3 combined. So we can see that COVID, the majority of ER visits are COVID related at 1.7% for this week, which is week 47 of the respiratory season, with influenza being a little bit second place, if you will, at 1.6%, and RSV being the lowest ER visits. But comparatively, combined, the respiratory diseases are increasing with every week. So that's kind of on par what we see with the respiratory season. And we're going to the middle of the respiratory season. So we're seeing all three of them kind of are integrated combined in these ER visits. So the next one is the percentage of respiratory visits by USET states. We made sure to, so you can see comparatively how each state is doing with respiratory visits compared to the United States. Louisiana has the highest rates of 6.7, with Maine and Rhode Island with the lowest at 2.4% and 2.5%. There's a lot of reasons why certain states might have higher rates than others, but we always want to make sure that we're monitoring each state individually so that if we see a huge jump in respiratory visits, we can indicate to our tribal nations that maybe they should be on the lookout for peaks or an increase in cases, and to maybe include vaccination campaigns and such. And comparatively, they're doing a little higher than the national average. So that's just a metric that, a rate that we're going to be monitoring for the next couple weeks. The next section is influenza. This is using the IHS weekly influenza report and the CDC surveillance report and HHS Protect. We like looking at the vaccination percentages. So the bar graph on the left is the seasonal influenza vaccination percentage by IHS region. And these are the 12 IHS regions that we usually see. The IHS region that is winning with vaccination percentages is Navajo at 35.4, but we are doing pretty good at 23.9%. We are seeing these vaccination rates also increase every week, so we like to see that, and it's continuing to increase with every week. The right bar graph is the national IHS seasonal influenza vaccination percentage by age group. We like to see two to three main age groups have the highest vaccination percentages, and that's the 6 to 23 months, the 2 to 4 years, and the 65 years and older, because they are our most at-risk age groups. For the national influenza, 65 years and older population has the highest vaccination rate at 43.4%, with 6 to 23 months having the second highest at 22.1% compared. And then in total, 22.6% of everyone 6 months and older is vaccinated for this year's influenza. So these are quite a lot of graphs and bar graphs. So I'm going to go one by one to make it a little bit clear. So the one on the top left is the percentage of positive influenza specimens by the type of clinical laboratories. This pie graph represents data collected from clinical labs nationwide, and it indicates which type of influenza we're seeing within the communities. So week 47, we're seeing that the majority of influenza cases are from influenza A, which I believe is an H1N1 strand, and then influenza B, which is an H3N2 strand. We like to monitor certain influenza strains for a couple reasons. The number one is that we like to see how effective the vaccine is against the circulating strains. And also Southern hemispheres like to watch our winter season to see if they need to tweak their vaccination for their upcoming winter. We also like to monitor the variants to make sure the strains aren't mutating or changing too quickly and could potentially become a problem in the future. Then the next graph or table is the one on the upper right, which is the IHS Nashville influenza vaccination percentage by age group. The previous slide was for nationwide and IHS areas, and this one is specifically for the USET area seasonal influenza vaccination rate. So we're seeing these two age groups are most vulnerable populations is 6 months to 17 years. and that vaccination rate is at 19.6%. I think it went up at least 1.5% since last week's respiratory report, if I remember correctly. And then seniors 65 years and older, we're seeing a really good vaccination rate of 47.5%. And I know that's increasing every week, so this is great news. The table on the bottom left is the number of new hospital admissions with influenza by HHS region. This indicates the total number of hospitalization admissions from the previous MMWR week, which is week 46, to the current MMWR week, which is 47, and it's based on HHS region. USET states are covered by 5 HHS regions, regions 1 through 4, and region 6. So we can see that region 4, which includes North and South Carolina, Alabama, Mississippi, and Florida, have the highest hospitalization rates with hospitalization admissions at around about over 1,000, 1,100 to, and then it's increased from 1,100 to about 1,200 within a week. And if we look at the bottom right bar graph, that's the percentage of these new influenza hospitalizations. So this table and this graph are interconnected. So we would see region 4, the 1,100 hospital admissions in week 46 represents 32% of all of the influenza hospitalizations in the HHS region. And then it's decreased a little to 30% to week 47. So these rates are, these percentages kind of vary from week to week, as well as hospital admissions. They can increase or decrease. So it's just something that we'd like to also monitor. And we'd like to see the changes from each week to see if there could be a peak from one week to a decrease in another. Next slide. Thank you. All right, the next section is COVID-19, our favorite. So for COVID-19, with the end of the public health emergency, the CDC changed what metrics are going to be focused on and what kind of variables they want to continue monitoring. And the 3 main things were the variant proportions of concerns that are circulating. And then one of them was the case positivity rate. So the COVID-19 variants concern, we included variants that represent 5% or more of the total variants being circulated. We focused on 5% or more because when variants are circulating at a certain percentage or more, they have a higher probability of spreading through communities at a higher rate. And then, so this week we have 7 variants that are kind of circulating at about 5% or more. HV.1, EG.5, BA.2, 0.86 are among the highest. If I remember correctly from looking at my notes, HV1 in week 47 has been circulating at about 30%. So the majority of the cases are like HV.1 and EG.5. And these are all part of the Omicron lineage. And so we like to just monitor those and update that week to week. Oh, can we go back, Emily? Sorry. So the weekly COVID-19 case positivity rate is, this compares the percentage of all COVID-19 antigen tests in the labs that were positive over the past week in both the United States nationally and within USET states. So we can see that over the last week, it is increased on the United States from 8.2 to 10%, and 6.43 from the USET states to 8%. Now we've been seeing really variable numbers. As you can see, it goes from it's increased and decreased and increased and decreased again. So we like to just monitor each all the positivity rates to see if we could be within a peak or not. And we just add that to the line graph. Next slide, please. Right, so we have two metrics on this one. The bar graph on the left is the weekly COVID-19 hospitalization rate per 10,000 people. On the CDC, it's the per 100,000 people. And we changed this rate to 10,000 per 10,000 people because the US population is as a whole is much larger than our USET states. So we just wanted to make it for an easier comparison. And so we see that this week, the US hospital admission rate is 0.59 per 10,000 people, and the USET state hospital admission is 0.5 per 10,000 people. This is increased slightly from last week. I think it's less, it's 0.04 for United States, and then about 0.06 for USET. So we're still just monitoring that. And then the bar graph on the right is the weekly number of COVID-19 hospitalizations. These are the total amount of people who've been hospitalized for COVID within the last week. And this can include people who are currently hospitalized and newly hospitalized. So these numbers change every week by quite a bit. So this week for the United States, we have 19,000 individuals who have been hospitalized for COVID. And then within the USET states, it's 5,800, which is much lower than the national. So we like to keep it that way, but we're also monitoring to make sure that there's no huge jumps in hospitalizations. And I think, yes. So that's it for this week's respiratory report presentation. We do offer an option for customized report specific to your tribal nation. It can be sent via email to tribal leaders and health directors, whomever would like to receive them. We can include customized metrics based on like HHS region, state, perhaps PERCTA counties and RPMS, but that's only depending on what's available. COVID-19 is a little bit trickier past specific past beyond state metrics and whatnot. So it really depends on what you're looking for and what we can provide you. And we'll definitely let you know if PERCTA and RPMS data is just unavailable. But you have to opt in to receive these reports. So you could just give us an email and we can provide that along with our weekly respiratory report. So if you have any questions, you can please contact us at usetepi@usetinc.org. If you have any questions or concerns or general assistance, if you'd like to give us feedback or questions about our seasonal respiratory report or based on our specific topics like influenza-like illness, flu, RSV, or COVID-19, we would be happy to field those questions if you would just contact Anna at agarrett@usetinc.org or myself at gharper@usetinc.org. Thank you. And the next slide is our QR code for our EPI webpage. Each week we do include our respiratory report in numerical orders. You can see each week since the start of the respiratory season if you want to see the graph changes and the percent differences within each week. Anybody have any questions?
I have one question.
Yes.
That was a great presentation. So are they locally where you work or in the hospitals or clinics in your area, are they using this data to make any changes in anything related to patient care that you know
of? Not that I know of, but I can absolutely find out. I have not fielded any questions personally about changes because like I'm just put together the data for the respiratory report. And if we see any huge changes, we would let the directors know so they can make the clinical determinations for their areas. But I'm not sure, so I can probably find out for you.
Okay, great. Thank you.
Well, thank you so much, Greer, for a great presentation. We'll move on to Dr. Mara. I've made you co-host so you can share your presentation if that's what you prefer.
Yeah, that wonderful. Thank you. Give me
You're
1 second. Let me pull it up. Can you see it there?
Looks good.
Okay. All right. So before I get started, here in the audience, how many people are treating HIV? If anybody, if you can put it on the chat. So nobody. So are there any medical providers, the PAs, nurse practitioners, physicians in the audience today? So Emily, help me out. I don't know everybody who's joined. Are there any medical providers?
I am looking through, not to my knowledge, but I have not gone through the,
So most of you are from public health, I would imagine.
I think so.
Okay. All right. No, I just want to see how I just needed to know that. All right. Okay. So the presentation that I was asked to give today was HIV, 101 on HIV. And I'll cover 4 aspects, a little bit about epidemiology and natural course, clinical presentation, diagnosis, and evaluation and management. But if there are no medical providers, I will not spend a lot of time on the management, unless someone's particularly interested. So, the human immunodeficiency virus, or HIV, was discovered in 1985, about 5 years after the first cases of AIDS started being reported. So AIDS was a clinical definition. And it was thought to be viral in origin, but it took about 5 years to discover it. And here you see an electron micrograph of the HIV virus connecting with a T cell, which is one of the main targets, and the one that causes the immune deficiency when these T cells are destroyed. So the way it is transmitted, it's either through sexual transmission, and I would say that's the main one, but it can also be transmitted by blood or blood products. So it's very rare that you would get it through a blood transfusion because the blood banks are checked for HIV. But injections that have blood from an HIV positive individual can transmit the infection. And we see this in people who inject drugs. Also, there could be needle stick injuries in the healthcare work setting. If you get a needle stick from someone who's HIV and not virally suppressed, there's the possibility of getting infected there too. Now that's occupational transmission. And then mother to child, it shouldn't happen because we have all the tools to prevent this. But if the mother is not treated and the baby is not treated, the risk of transmission is about 25%. And here on the right-hand side, you can see the body fluids that are typically infectious because they contain high quantities of virus or blood, breast milk, semen, vaginal secretions, and any fluid that has visible blood on it. So if you get exposed with any of these fluids in your mucosal surfaces or an open wound or injected, you can acquire HIV. Now, HIV is not transmitted by insect bites, by sitting on a toilet, kissing, sharing, eating utensils, touching, hugging, by mosquitoes, etc. So now I think most people have this clear in their minds, but when the epidemic started in the 80s, there were a lot of concerns that many of these transmissions could happen. And so there was a lot of panic in the community. But as time went by, it was very clear that urine, saliva, sweat, tears, nasal secretions, sputum, GI content, stool do not transmit the virus unless they have visible blood on them. Regarding Native Americans, although there is a decrease in HIV incidence in the United States, it has been decreasing in the last few years, like from 50,000 a couple of years ago to 34,000 cases a year. There has been a slight increase in American Indian Alaska Native population compared to other ethnic groups. And 80% of Native Americans who are HIV positive know they're HIV positive. It's a little bit higher in the other ethnic groups. And of those who know that are HIV positive, only at 63% are taking medications that virally suppress them. So there's a lot of work to do here because, one of the ways to cut the pandemic or the epidemic of HIV is to make sure everybody knows their status. That way they can access treatment. But the other issue is, even if you know your status, you need to have access to healthcare and to the medications and to be adherent to the medications. And that's where we need to work a little bit more on. One of the main concerns and differences of HIV in Native American populations is the way they acquire it. When you look at females, almost half of the females acquire HIV through injection drug use in the Native American communities, compared to 9% or 6% in the other ethnic groups in the United States, and compared to less than 1% in countries which have very robust harm reduction programs, meaning syringe service programs. And when you look at Native American males, they also have a 15% risk of acquiring HIV when injection drug use is involved. So those are two areas that are important to address because they are preventable and there's interventions to mitigate them. So, there's sexually transmission. I mean, HIV is sexually transmitted, but not all types of sexual encounters have the same risk. And the highest risk is receptive anal intercourse. And that's why MSM, or men who have sex with men, are at higher risk of acquiring HIV from a positive HIV individual than other people who may be engaging in other forms of sex. And here you have the types of sexual encounters and the risk per 10,000 exposures of getting HIV. So receptive oral intercourse or insertive oral intercourse, the risk is extremely low. There's not good studies delineating it, and that's more of an expert, assessment, but it's not a big concern. And why do we need to know this? Because when someone gets exposed and they're looking for post-exposure prophylaxis, the risk of the exposure is taken into account to make a decision of offering or not offering that person PEP or post-exposure antiviral prophylaxis. You can see that blood transfusion would be the highest rate, but the blood banks are safe. And that's why it's not a concern. But needle sharing, 63, it's about half of receptive anal intercourse. But if someone, and this is, if someone is getting exposed consecutively, the risk of getting infected will increase. So because the HIV incidence was coming down, but not going to zero and kind of staying in 38,000 per year, the United States came with a plan of ending the HIV epidemic, and they initially targeted with interventions 48 counties that were high-risk counties, meaning they have high incidence of HIV already or have social determinants of health that put them at high risk of increasing HIV. And 7 states that are delineated in light blue in the map, and the majority, if not all, are in the southwestern part of the United States. And the pillar for preventions are to test everybody per guidelines and diagnose them. If they're positive, engage them and treat them. And if they are negative, but they are at high risk of acquiring HIV, for example, they may be an MSM with multiple partners, not using condoms systematically. That's a high-risk individual, or someone injecting drugs and sharing paraphernalia with people who are known to have HIV, or you don't know their status. So those are high-risk situations. You could offer them beyond counseling and condoms treatment, pre-exposure prophylaxis with medications, with antiviral drugs. And then the last intervention is basically respond quickly to an outbreak. That's more on the health department's realm, because they have to be monitoring, the incidence of HIV in your community, and if there's any red flags that may point to an outbreak, they should be the ones responding to that outbreak. So a little bit about terminology of HIV. When we talk about the viral load, is a measure of the quantity of HIV particles or individual virions per ml of blood. CD4 is the absolute number of CD4 cells, which are a subset of T lymphocytes, and there are critical lymphocytes in protecting our immunity. The reason that people who are HIV negative or have a normal immune system do not get infected every day, or do not succumb to rare infections, or not presenting with tumors every day, is because their immune system, especially the CD4 count cells, have a good number and good quality of function and protect you from all those infections and tumors. So acquired immunodeficiency syndrome is someone who has signs or symptoms that their immune system is not working well. And basically, they're developing these opportunistic infections or tumors that are not very common, or some are common, but they develop it at early ages or more frequently. And if you have someone, before we could have the virus identified, anybody who presented like this, and we could not have a good explanation of why they were immune deficient, meaning they were not getting cancer treatment, or they did not have a congenital immune deficiency, they would be labeled as having AIDS. And also, if you have less than 200 CD4, or less than 14% of your T4 cells, or less than 14% of your lymphocytes, regardless if you have an opportunistic infection or cancer, you also are under the category of AIDS. And ART is the most common way that the most common acronym for antiretroviral therapy, which is the antiviral treatment that we use to treat HIV. In the past, there were many other names. They would call it HART, or the patients would call it the cocktail, because they would take like 20 pills a day. But now ART is the preferred term. Okay, so here we have a cartoon of a CD4 cell, and the CD4 cell has these receptors that are called CXCR4, and there's also another receptor called CXCR5, and these receptors are important for the virus to bind and enter the cell. And they're so important that people who don't have CXCR5, for example, that they were lucky enough not to have those receptors, cannot get infected with HIV. They're immune to the HIV infection, but it's less than 1% of the population. So once the virus enters, it's an RNA virus. It has an enzyme called reverse transcriptase, and that enzyme turns the RNA into DNA, and that DNA is incorporated in the chromosomal or human DNA. And that's one of the reasons that it's so difficult to cure this disease, or almost impossible, because you can use antivirals to kill all the virus that's replicating, but you will not be able to target the virus that is integrated with the human DNA. And that remains silent for a while until it starts replicating and the infection comes back. And that's why we can't cure HIV yet. And that is why we can cure Hep C, because Hep C does not integrate into the to the genome of the human. It's in the cytoplasm only. So what the virus does is, with time, destroys these cells, and these are the cells that are important for our immune protection. So if you want to look at a timeline of what happens over weeks, months, and years, when a patient gets infected here, initially there's an increase in the viral load because the virus is multiplying, and the CD4 cell counts may take a little dip, which it recuperates pretty fast. But then over time, which is months or years, the CD4 cell count starts decreasing. And when it gets to a level of around 200, that's when the problems start appearing, meaning the opportunistic infections and the tumors. Now, this phase that you see here plotted as a 15-year phase, it could be shorter for patients. I've seen patients, dip below 200 CD4 after 5 years of infection. And then there's a very few percentage of patients that are called elite controllers that really never dip their CD4s too much, and they always have a very low viral load. They control the infection pretty well, but it's also a small percentage of them. So as time goes by, initially, someone who's HIV positive will probably not know they're HIV positive unless they get a test done, and they'll be fine. They will be healthy and not show any other symptoms. But as time goes by and their CD4 cell count starts decreasing, they start with symptoms that could be weight loss, ulcers in their mouth, dry skin, itchy skin. And then when their CD4 dips below 200, that's when they start getting all these infections. And these infections could be tuberculosis or pneumocystis cerevisiae pneumonia, or cytomegalovirus in the retina, or toxoplasmosis, infections that people with normal immunity usually don't get. Well, tuberculosis, you can get it with normal immunity, but they get it more frequently. And then if the patient's not treated, at some point it'll succumb to one of these infections or a tumor that are usually lymphomas, but they're also at higher risk for other tumors like lung cancer, etc. Okay, so the clinical presentation, and this is where we have the problem that many, and that's why I was asking if there were providers here, that providers sometimes don't recognize. So a patient usually, the most common scenario is the patient doesn't have any symptoms. So the only way to diagnose them is to screen them. If you don't screen them, you can't detect the infection. And then there's a group of patients who are symptomatic. And the ones that are mostly missed are the ones that are present with an acute retroviral syndrome. And I'll talk about this a little bit. So they present with an acute illness that's misdiagnosed for something else. And then the patient recovers spontaneously, and the diagnosis is not made. And unfortunately, what we're seeing more lately is that last bullet, in which is patients come in with an opportunistic infection or tumor, meaning they've had HIV for years and nobody has detected them, and they suddenly get sick with a unusual infection or unusual presentation of a tumor. And in this last 2 years, I've seen more than 5 or 6 patients present this way. So the acute retroviral syndrome is when the patient gets infected for the first time, usually presents 2 to 4 weeks after the patient's been exposed, and it's usually 2 weeks. Most of the time it's symptomatic. And the problem is that the symptoms are not easily recognized as being part of HIV, and they go unnoticed. And you have a list of symptoms there. If you can see, fever, pharyngitis, myalgias, rash, GI complaints, all that could be COVID, or that could be influenza, or that could be a tick-borne illness. So, or it could be any other viral infection. So if you're really not keen in testing the patient, you're not going to pick it up. So any patient who comes with an acute infection, if they've never been tested for HIV, or if they have been tested, but they are a high-risk individual, meaning you took a sexual history and you know that you can categorize them at higher risk, they should be tested. And on the right, you see the maculopapular rash. That's pretty common, but not typical. It can be caused by a drug reaction. Could even be confused with a syphilis rash. But it is present more frequently than what we think. And when these patients usually get their labs, they usually have pancytopenia, low platelets, low white cell count, elevated liver function test, And so there's nothing very specific about it. But one caveat is that if you test them with antibodies against HIV, they could be negative because I'll show you it takes a little bit of time for the antibodies to pop up. And on the right, you see the differential diagnosis. There are other diseases that mimic this presentation that need to be considered in the differential diagnosis. The most common one lately, I would say, is syphilis. But, Epstein-Barr, CMV, and viral hepatitis can present the same way. And if the patient has the acute infection and goes undiagnosed, years later, they will come up with some of these opportunistic infections. And here in this cartoon on the left, I kind of put the main ones. On the eyes as CMV retinitis. And actually, we had a patient that actually he was screened and he was positive for HIV, and his CD4 was extremely low. And we started treating him as HIV. And then a couple of weeks later, as part of an immune response inflammatory syndrome, he developed a CMV retinitis. Or they can come with thrush in their throats, or they can have tumors like Kaposi sarcoma in the skin or other types of tumor. Or they can come with recurrent, difficult to treat herpes simplex infections. And then the more serious things are brain lesions due to infections like toxo, cryptococcal meningitis, or tumors. And then in the lung, they can have pneumocystis. It was called PCP before, pneumocystis carinii. Now it's called pneumocystis jirovecii or Jirovecii pneumonia. And also tuberculosis or atypical bacterial or even fungal infections. Lately, I've seen 2 patients with histoplasmosis, one disseminated, one was just a bad lung histo. At the same time, they were HIV positive, and they did not know they were HIV positive. One way to figure out what is the risk of these patients is look at their CD4. So if you have more than 500 CD4s, you're not going to get many of these things. You still have a good immunity. You may get tuberculosis. But then when the CD4 starts dropping, you can see that these diseases start adding up. And when you have less than 50 CD4, you can have tuberculosis, pneumocystis, Mycobacterium avium, Cryptococcus, histo, CMV. Basically, you can have anything. So this is a case that I saw many years ago, and it was a 32-year-old Native American female who presented to the emergency department for the 4th time in 1 month, complaining of worsening cough, chest pain, and fever and dyspnea. Patient was pretty sick, was saturating 54%, was very tachypnic. And one thing that came up when we were evaluating is we were assuming that this patient had had an HIV test done since it was the 4th time she was coming in. And the answer was no. And we did an HIV, a rapid HIV, and it was positive. And what the patient ended up having, you can see the CT scan, looks very similar to COVID, these ground glass opacities that are bilateral. But this was pneumocystis jirovecii, which is a fungal infection. You can see in the dark blue stain, the cysts of the pneumocystis carinii. I'm sorry, jirovecii. And while this patient survived, we treated her, but it took a while for her to get better. She was hypoxic for a long time, on home oxygen for several months. And when we looked at the medical records, that patient had been in our system for the last 2 years with multiple encounters, never tested for HIV. This is another not so fortunate fellow that I saw in the emergency room, and he was a patient that was brought from the prison, and he had been seen 7 times in the ED in the last 2 months. And the main complaint was headache. But when I saw him, he had headache, he was confused, he had a very high fever. Again, patient never tested for HIV. We did a rapid test, it was positive. Then we did an LP, and lo and behold, the patient had these yeasts in the CSF with this is the yeast and this is the capsule, because the Cryptococcus has very thick polysaccharide capsules. And he had cryptococcal meningitis, and despite the fact that we treated him very aggressively, he passed away 5 days later. And it was sad because this patient could have been diagnosed before and treated properly, and probably survived. This is just the CDC classification of patients with HIV, and basically it's based on the CD4 cell count and presence of opportunistic infection. So Stage 0 would be an early HIV infection, like you just got it. Stage 1 is that you have more than 500 CD4 cells and no symptoms. Stage 2, your CD4 cells drop between 200 and 500, but you still don't have any AIDS-defining illnesses. And stage 3, you're below 200, or you have an AIDS-defining illness. And well, the last one is that you don't have enough information to classify the patient. Okay, let's spend a few minutes on diagnosis, which is important. So there are screening guidelines, and basically anybody that's 13 to 64 years old should be screened at least once in their lifetime, or any time that they have been exposed to HIV. So how do you figure that out? I mean, let's say a kid comes in, he's 14, is healthy, you do an HIV screen, is negative, and the recommendation says once in a lifetime. So it seems like he's protected. He won't get HIV the rest of his life. Well, that's not true. So this kid will at some point, or may at some point, engage in sexual activity, or he may be unfortunate and end up using drugs. So every time you see a patient, you should look at when they were screened for HIV, and let's say it was 3 years ago. And there's a simple question: since you were screened for HIV 3 years ago, have you engaged in any activity that puts you at risk? And if the patient doesn't know what that means, you explain it to them. So basically, have you had sex with someone who's not your stable partner and is HIV negative without condoms? And if the answer is yes, then you need to check them again. Or have you injected drugs, if they happen to inject, and shared your paraphernalia? And if the answer is yes, then you need to check them again. So, of course, this doesn't happen as much as we would like to, but that's what should happen. And of course, all pregnant women should be tested. That's the only way you can prevent vertical transmission. So HIV screening and testing is basically an opt-out screening. Opt-out means that you tell the patient you're due for your HIV and whatever other tests they may be due that day, let's say your cholesterol, etc. So we're going to do it. That's it. Unless the patient stops you, you go ahead and test them. Now, if the patient stops and says, hey, I really don't want my HIV test, then you may want to engage in a conversation to explain why it's needed. If he still refuses, you don't do it. But it does not require any pre-testing counseling or no pre-testing counseling. Of course, he ends up being positive, you'll have to do some post-testing counseling, but not for the negative ones. And also have in mind that different states have different laws regarding when minors can consent for testing of STIs, including HIV, and preventive treatment or treatment. So they do not need to inform their parents if they don't want to. Not that we encourage that. It's always better when the family knows, but it's up to the individual to make that decision. You have to look in which state you live and what are the rules regarding age and consenting for all these interventions without parental consent. So here's the virus, and the tests that we have are either they target a surface protein of the virus, which is the antigen, or they target the antibodies that the body produces against the virus, and they could be IgM or IgG antibodies, or the diagnostic test may target the molecular part of the virus or the RNA. So that would be like a viral load or a nuclear test, or a PCR. There's different ways of expressing this. Just to clarify some maybe confusion, we have first generation, second, third, and fourth generation tests. Well, the bottom line is that we should only be using fourth generation tests. The first test that was done measured an IgG, and the lysate that was used was from crude viral lysate. That's meaning they crush the virus, put it on a plate, and then do the test and see if you have antibodies that would stick to that virus. Then second generation, it was same deal. It said that except that the antigens used was not a crushed virus, but it was recombinant molecules of the virus. Then the third generation incorporated IgM on the testing. So you would pick up IgM and IgG. And the fourth generation incorporates the antigen. So you pick up the antigen, IgM, and IgG. And why is this important? I think I have the wrong slide here. Let me see if I think I eliminated that slide. Okay, I'll tell you why it's important. It's important because the timing of the appearance of these molecules that we're testing is different. So if you're detecting an IgG against HIV, it might take you 35 to 45 days to detect it after the infection is done. So in an acute infection, the test will be negative for almost a month. If you're looking at IgM, then that gives you a little bit better, detection period. It shortens it to maybe 25 days. If you're detecting the antigen, it may shorten down to 15 days. And if you want to test the RNA, it may go as low as 5 to 10 days. So this is important when you're testing someone who's been exposed. So what test do you use and how to interpret that test after the exposure, depending on the timing of the exposure. But the bottom line is that we use fourth generation tests. And these, as I mentioned, these fourth generation tests detect the capsid of the virus or the antigen, the IgM and IgG antibodies that we produce against the virus. There are 6 FDA-approved laboratory-based immunoassays, but they all require confirmatory testing. So that this test is positive does not confirm that the patient has HIV, because we see quite a bit of a false positive test. And a negative test does not rule it out because it depends when the patient was exposed. The confirmatory test is also an antibody test that has changed from the past that we used to use Western blots, which were antibody tests, but done in a different way. So the confirmatory test or the HIV 1-2 differentiation assay detects HIV1 and HIV2. In the United States, 95% of the HIV infections are HIV1, but 5% are HIV2. This test, both tests, the screening test and the confirmatory test will detect it. But if you're using an RNA test, we usually use HIV1 RNA. We don't use HIV2 RNA. So you can miss an HIV2 infection just by using RNA, unless you ask the lab to do an HIV2 RNA, and not many labs can do that. So if your test is positive here, then it goes to this test. And if it's positive here, then bingo, your patient, not good for the patient, but the patient has HIV, either HIV1 or HIV2. And very rarely they could be infected with both viruses. So there are also single-use point-of-care tests. The other ones I mentioned before of the fourth generation were lab tests. And these point-of-care tests are a little bit less sensitive than the lab tests, but they're more practical because you can do it, bedside or at the point-of-care level. It takes 20 minutes to result, but they also need to be confirmed with that differentiation HIV1, HIV2 assay. So here is a graph of when the infection occurs. Here, HIV infection on day 0. So the eclipse period is the time in which there will be no test positive. So during the first 10 days of an infection, there's no test that can help you diagnose the infection. And you need to know that because you'll need to retest that patient. Now, the first thing that you will detect is the HIV RNA, then the HIV-24 capsid antigen, and then the antibodies, first the IgM and then the IgG. And you can see here that the antibodies, especially the IgG, you will see it like 45 days after, you may see it up to 45 days after the infection. So the limitations of the test is that none of the initial antibody or antigen screening tests or the fourth generation tests are considered definite for diagnosis. You need to confirm it, and you need to explain that to the patient. No single test is capable of detecting HIV immediately following infection. So there's that 10-day of an eclipse period, and some patients may go undetected if they got infected very early. This could be after a sexual exposure or after a needle stick, etc. So here you see there are some causes of HIV false negatives. It's usually because the infection is very early and your test is not detecting it. Also, people who are taking HIV PrEP may suppress the response to an infection, and it might take a little while more to get the test positive. And then there's a whole list of false positive causes like pregnancy, autoimmune disorders, recent influenza vaccination, any other viral infection, prior blood transfusions, or mistakes in the lab. So this is the interpretation algorithm, and I'll walk you through it real briefly. So you do the 4th generation test, which is the HIV-1 antigen, HIV-1 and 2 antigen and antibody test. If that's negative, then the patient's negative, unless you pick them up too soon and he came on day 10 after exposure, and you will not pick this up. But let's say that's not the case. Then if the test is positive, you do the differentiation antibody immunoassay. And depending on which one's positive, the HIV-1 is positive, it means the patient's confirmed has HIV-1. The HIV-2 is positive, it's confirmed they have HIV-2. If both are positive, they have a co-infection with these viruses. But it could happen that they both are negative, so you're in a conundrum there. So what's going on? I mean, the 4th generation test was positive, but the confirmatory test is negative. And that's when you do the RNA. And you do an RNA HIV-1, and if that's positive, then it means the patient has the infection. But if it's negative, the only possibility is that the patient could have HIV-2. There's 2 options on what you do. You send it for an HIV-2 RNA, which is expensive, cumbersome, or you wait a couple of weeks and repeat this differentiation assay, and the HIV-2 will probably be positive by that time. Okay, now I won't spend okay, let me check again. Are there any medical providers here, PAs, nurse practitioners, or physicians? Okay, I'm assuming that if you're not putting anything on the chat, you're not, or you fell asleep. And in any situation, you won't learn much, even if I do this presentation, but I'll just go briefly through them. So on this slide, you can see all the tests that you need to order when you confirm an HIV positive individual is HIV positive. And these are the tests that you will need to be able to start treatment and evaluate them. So it's basically a bunch of other STI tests, a full hepatitis panel, a resistance test for HIV. That's very important. You will need to make sure that you're going to treat that patient. You need to make sure that they're not resistant to any drugs that you're going to be giving them. And the goal of therapy is to virally suppress that individual. So if he's got 200,000 copies circulating in his blood, you need to get him to less than 200 copies to be ideally non-detectable is what we should shoot for. And why? Because it'll be good for that patient, but also if they're undetectable, they cannot transmit the infection to anybody. That's their goal. We have 3 classes of antiretroviral agents that we use, and they act at different levels on the replication cycle of the virus. So we usually use integrase inhibitor, which is the enzyme that integrates the virus to the human DNA. And this is this one here, the integrase strand transfer inhibitors. We use a lot of reverse transcriptase inhibitors. That's the enzyme that changes the RNA to DNA. And although we used in the past a lot of protease inhibitors, we don't use them that much anymore, but they're available. And why? Because they have more side effects and they have a little bit more toxicity, but sometimes we need them. The treatment is pretty simple. There's 2 main recommended regimens. The first one is a 1-pill regimen. Okay, both of them are 1-pill regimens now. But the tenofovir emtricitabine bictegravir is the treatment recommended of choice. Very well tolerated and very potent regimen. But if for whatever reason the patient cannot receive this, for example, they have renal failure and their GFR is less than 30, then the abacavir, lamivudine, dolutegravir would be a good option. But you need to test this genetic marker, the HLA-B5701, because patients who have this positive may have a very severe reaction to abacavir and could even die from it. So they need to be HLA-B5701 negative before you use this regimen. And they'll also have to be HBV negative because the first regimen is very potent hepatitis B drug also. But the second one, lamivudine, does not have a great potency. So if the patient has Hep B, you would prefer the first regimen. In certain patients in which they have a very low viral load, less than 500,000, they're HBV negative, and the sensitivity testing came back that they're sensitive to these 2 drugs, you can treat them with a 2-drug regimen only, which is dolutegravir and lamivudine. What is the advantage? Is toxicity. So you have less, less side effects. But it's very select number of patients. And then you follow their RNA for, there's specific schedules for that. But usually what you're following is that the RNA is coming down nicely, and at some point it goes to undetectable or less than 50 copies. And once they're virally suppressed, you check them, the RNA, every 3 or 4 months. The CD4, you check them at baseline, and then you check it every 3 months until the patient has a good number of CD4s. The great numbers above 500. And after that, to be honest, you don't need to check CD4s anymore. As long as the patient's taking their meds, and as long as they're virally suppressed, once they hit the 500 mark, they're going to be fine. Some patients that you run into when they're very immune compromised because they were diagnosed for years and they were not diagnosed for years and their CD4 came down, you need to start giving them some antibiotics to prevent infections that are listed here. The Pneumocystis carini, like the first patient I presented, or Zervecii, the Toxoplasmosis, Mycobacterium, Cryptococcus, etc. So you go by a chart that has the number of CD4 the patient has, and what is the suppressive treatment or preventive treatment that you need to put that patient on. Now, this is not for life. This is until the patient recovers their CD4, and after a while, you can stop all these antibiotics. Here's the immunizations recommendation, and the main thing to remember is the red thing. So live viruses are contraindicated, especially when the patients have less than 200 CD4 count. If they have more, then you can explain to the patient and probably vaccinate them. And then there's a lot of health maintenance issues because these patients really, when they're taking their antivirals, they don't die of HIV. They will die of heart attacks, of strokes, of cancer. So it is very important to do your regular cancer screening plus anal and cervical paps in females and anal paps in males. And there's a schedule for how often you do them depending on the results. And this is for early detection of cervical cancer or anal rectal cancer. You need to vaccinate them, and then you need to make sure that they're doing okay and that they don't need any behavioral health support for anxiety, depression, PTSD, etc. The main thing that I didn't mention is tobacco cessation, because all the cancers that are increased in people who have HIV is because of tobacco. So you need to make sure that you offer them smoking cessation. And I will stop there. See if there are any questions.
Well, thank you very much. If anyone has any follow-up questions, you can always send them to Dr. Mara or USET staff. Again, we are offering continuing education credits. You have to complete the survey. And next month's topic in January is going to be COPD and linkage to other infections. And Dr. Mara will be presenting that. And thank you, Greer and Dr. Mara.
Thank you. And Dr. Brown is also going to be presenting that. Don't forget him.
Dr. Brown will be there
Yes.
too.
Can't get away with it.
I have that written. No, okay, yeah.
Okay. Thank
Well,
you.
have a happy new year, everybody.
Thank you.
Yeah. And I'll send you this final set, which I edited a little bit compared to the one I sent you previously. Okay.
Yep, thanks.